Gula, also known as Ike. Ike is a formerly trained health informatician with a background in computing. Previously, he completed a Master of Information Technology with a health specialization at the University of Melbourne with the support of the Australian Endeavour Scholarship. Ike is currently a candidate of the Fellowship by Training program of the Australasia Institute of Digital Health. And we would like to extend our congratulations to Ike as he has recently submitted his PhD thesis for examination. And for his completion seminar today, he'll be presenting on designing a framework to measure patient-reported health effects and outcomes from using person-generated health data, a simulated rehabilitation system use case.
All right, well, thank you for that introduction. And hi, everyone. Welcome to the talk, and thank you for joining me on the lunchtime to talk about my thesis and what I've been doing for what I have done for the past 4 years. Now, as you might have heard from Kathleen a while ago, this is a bit of a groundhog for a few of you. For a number of you who attended this talk, a similar talk in September last year. So I do apologize for that, but I do hope that you'll still gain something from it. There have been some new insights, a few here and there, since my presentation last September. And I've also been able to publish a few more papers since that time. So throughout my talk, I will be mentioning those publications because I've tried to structure the talk around those publications, and they will also serve as signposts. Finally, I will, from time to time, probably be saying we about my results or work instead of I. And that's because, again, because of those number of publications, I've gotten used to saying we because I have co-authors. But I can assure you that as per University of Melbourne regulations, thesis with publications must include, or at least must have at least 50% of the PhD candidate's work. And I did contribute more than 50% in all of the publications that I have. Okay, so we'll begin. And again, my topic is around, what I really did in my PhD was to develop a framework for measuring outcomes on people's use of health data they generate from health information technologies. Sorry. Yeah. Okay, so what's person-generated health data? For many of you, you probably know what it is already, but essentially when patients or people use a particular health technology that they generate, and they generate data themselves, that data is what we call person-generated health data. A different form is also, a different name for it is also called patient-generated health data. And we know that there are varying potential effects of PGHD. For example, some of the positive or benefits that you can get from using PGHD is improving health management coordination and also assisting in self-management of care. And it can also engage patients in their own healthcare. However, some studies have also reported that it can make patients feel excluded and that it may even discourage them from obtaining some of their health goals. And some studies also report that it may not have any effect on their health behaviors. It can have a nil effect, neither positive nor negative. So it's obvious from this that we really need more evidence for the effects of PGHD use. And a lot of headlines really sort of highlight that as well. For example, can activity trackers really help you get fit? That they don't help you lose weight. Do they actually help you with improving your motivation with fitness? Dark side of wearable fitness trackers. And activity trackers could be better, so why aren't they? Now, of course, PGHD is not just is not only a product of wearable fitness trackers, but this is a very popular example. So why could there be very varied effects of PGHD use? Could it be because for some people, they consider the data new, and there are also some questions on accuracy, like how accurate their PGHD is. For example, how accurate your particular type of data you're producing from a particular technology. There are some questions around that still. Is it because people who are more inclined to stay healthy are only the ones who really benefit from it? And more research is needed in that. Could it also be device fatigue? There was a study a few years ago on how Fitbit users really only use their Fitbits up to 6 months, and then they start, weaning off the technology. Is it because their data seems non-meaningful to them? And obviously, all of these questions have relevance to evaluation and design. So why don't we consider the P in PGHD, the person, the people? We know that if we ask people themselves or patients themselves about their health data, we know about their healthcare, we know that we can understand some of the factors that may affect their motivation. We know that we will be able to find out what kind of health outcomes they might want to achieve. And we will also know whether their state of readiness and whether they need additional support. So we need more evidence. PGHD's effects have not yet really been empirically demonstrated or defined. And currently patients have no systematic way to measure and report those health effects. Now, it's not new, this idea of allowing patients to self-report certain effects. Measuring patient-reported effects is common in the health space. We can ask patients to self-report their health status, their outcomes, their experience of healthcare services. And they do this using distinct types of standardized measures, which could be in paper form or in electronic or online form. And some of the key patient-reported measures are what you call the PROM, the PREM, and the PRMS. So you have the patient-reported outcome measure, which really focuses on the health outcomes and status that patients can report. Patient-reported experience measures, which again, based on the name, refers to allowing patients to self-report in a systematic way their experience of a healthcare intervention, for example. And patient-reported measures of satisfaction, which is really a more specific type of measure, really trying to capture a very specific indicator, which in this case is satisfaction. And measuring patient-reported effects using those measures have been proven to help us understand the impact of healthcare services on patient status and quality of life. And they can contribute to the comprehensive and accurate assessment of patient outcomes and the effectiveness of healthcare services and interventions. And therefore, they are useful in guiding best clinical practices. We also know that using those measures can complement clinician reports and other biometric data from certain technologies. And so it's really a very patient-centered approach, allowing patients to self-report their health outcomes or their experience, which is really complementary to clinician reports and biometric data. And therefore, they can assist healthcare providers to improve patient services and systems for improved healthcare outcomes. And they can also gather information about events in the patient care pathway to better understand those health services. So what's the overarching research question of my thesis? And it's this: how could users' reporting of PGHD effects be standardized for any given PGHD technology and health condition? And again, this goes back to everything I discussed about the need for more PGHD evidence and effects, the significance of really focusing on the P in PGHD, and knowing that there are a lot of benefits with allowing patients to self-report systematically their experience of particular healthcare intervention. So what was the methodology I followed? And I will be discussing it here, and it will also serve as a sort of a guide for the rest of the presentation. I followed an interpretivist paradigm because I generated a framework from patients' perspectives on their experiences and their outcomes. I considered the socio-technical context of health information technologies from which PGHD is produced. So from the definition of PGHD, they are produced from particular health incubation technologies, and so obviously it has this socio-technical context or component. I selected a PROM, a patient-reported outcome measure, from the PREM, the measures of experience and satisfaction, and other options. I selected the PROM to measure PGHD utilization, and I will be discussing more later why that is. And then I reviewed the best practice methods for developing PROMs. And then I augmented that method accordingly in consideration of PGHD to develop the measure. Now, this is the framework that I really that my entire thesis really led up to. And I'm showing this early just to sort of, again, structure the talk and to give you a better idea of the process. And there's a socio-technical consideration for the health type, for the health technology. You know, I conducted an interview. I selected a specific type of a patient-reported measure. I reviewed the PROM development best practice, as I mentioned, and then I developed it, and then I have some outputs, which I will be discussing throughout the talk. All right, so let's talk about some of the key outcomes and results really from my thesis. So I reviewed again different PROM development methods and sort of focused on what's called the qualitative item review as a suitable foundation for PROM-PGHD development. And it has specific steps that really includes patient perspectives, which really influence PROM development. And that's one of the key reasons why I chose QIR, or qualitative item review, because of that focus on really gathering patient perspectives to influence PROM development. And the method was recently published in the JMIR, Journal of Medical Integrated Research Protocols. And from that paper, we identified there were 5 steps really in terms of developing a new patient-reported outcome measure of utilizing PGHD or PROM-PGHD. And the step 1 was augmented to consider socio-technical domains, and it's essentially a literature review. The step 2 is called binning and winnowing. Binning in this case is more, I think, is more of an American term of actually categorizing or grouping, and not really binning in terms of the Aussie term of throwing something in the rubbish bin. Winnowing means weaning or removing some items. And I also augmented this step, to consider PGHD in the content of the PROM items. And step 3, initial item revision, was also augmented to revise items in consideration of socio-technical domains. And step 4, patient input was elicited to improve the initial PROM-PGHD. So essentially, from the first 3 steps, an initial PROM-PGHD will be the result, and then step 4, you elicit patient input to improve it. And step 4 and step 5 were not augmented. And step 5, final item revision is conducted to apply recommendations for improving PROM-PGHD. And essentially, I conducted a stepwise approach of involving patients, and there's a focus on participatory approaches because we argue that they generate a rich and deep understanding of health technology intervention effects. And it's really important for practitioners and developers of health technologies to prioritize the patient perspective. And it's also really important that practitioners and developers are sensitive to how PGHD may affect people differently. And some of the studies that I'll be discussing later highlight that need, really, this sort of need to really prioritize patient perspective and to be sensitive to how PGHD affects people in different ways. And again, there's a need to ensure the patient perspective is embedded into the resulting PROM-PGHD, and that's what that's what I have tried to do in my PhD. All right, so the step 1 on literature review, this was published in 2018 in, the JMIR Rehabilitation and Assistive Technologies. And as you can see here, again, talking about the socio-technical component, the case study that I really focused on was the health condition of stroke, and the technology case was simulated stroke rehabilitation technologies. And I chose that because of an earlier interest before jumping to my PhD into really looking at sort of telehealth component and looking at helping people with difficulties in accessing health recovery centers in the Philippines and helping stroke patients recover. And a simulated stroke rehabilitation technology, which allows patients or stroke survivors to perform some form of rehabilitation in their own homes or in stroke clinics closer to their homes, is something that I was really interested in to bridge that gap in access. So in the review, I examined the extent of PGHD use in studies of simulated rehabilitation systems for stroke. And I discovered that other reviews did not really consider the effects of PGHD use. From the review, I identified outcome measures from which candidate items were drawn for assessment. So from the literature review, I identified some PROM items that could be assessed for the next 2 steps to develop a PROM-PGHD. And I noted that only one paper really documented any effects of PGHD use, which is an increase in motivation. All right, so the next step is to really analyze those the insights from step 1 and then conduct steps 2 and 3. And that was done and presented, or rather reported, in this paper published in BMJ, Health and Care Informatics, last year. And we, essentially the PROM items from step 1 that I mentioned were assessed for relevance to PGHD and then categorized according to the binning and winnowing activity. Some of the items included were revised to consider PGHD utilization effects. And some of the included items were also revised to ensure consistency of the response options, wording context, conciseness, simplicity of wording, and so on. And this is the initial PROM-PGHD item bank that we have presented in this paper. And I know it's a bit small, but I zoomed in a bit here, but I don't think it's that big or that clear. But essentially, you have a question there on what kind of feelings were triggered for them on seeing the information that Getronics provided about their rehabilitation. I felt hopeless, I felt hopeful, discouraged, encouraged, and so on. So again, some of these items were really drawn from the literature review. They were then assessed for relevance to PGHD, conciseness, and so on. They were revised a bit. But the missing element here is that they have not really been presented to patients yet, or we have not really gathered perspectives or health effects directly for patients yet. So that's why it's called the initial item bank. And that's why the next step is the step where we gather feedback or input from patients. But before that, some of the interesting considerations that I had to do in the first 3 steps is the need to include self-report measures in the technology category, because obviously PROM sprints and patient-reported measures of satisfaction really belong in the health space, and they're not really utilized in the technology literature. And that's why I had to include self-report measures, including experiences and satisfaction of technologies, not really health interventions alone. And that made really the kind of items that was included in the PROM-PGHD sort of really richer in the sense that it really considered both spaces, both fields, both contexts. And again, as I mentioned, the next step was to elicit patient feedback, and the results from my studies were presented or reported in the first instance in MedInfo last year, and which was published in Studies of Health Technologies. And the second one is forthcoming. It's currently under publication stage, processing stage. Before publication, I've already, copy edit and then proofreading stage. in B&J Healthcare Informatics. And for these studies, I conducted focus groups and semi-structured interviews with stroke survivors in 3 sites: Deakin University, Austin Health Hospital, and Headway ABI, an outpatient stroke rehab unit in Queensland. And I also conducted discussions with clinicians from Austin Health. So in Austin Health, I conducted discussions with stroke survivors and clinicians. And the human research ethics were approved by Deakin, Austin, and University of Melbourne. And in the discussions, I asked participants to comment on the concepts and items of the initial PROM-PGHD item bank. And then I asked them open-ended questions on what their experiences were on accessing and using their PGHD or their health data. And I gathered concepts that may not have been covered by the current items. So the findings: some of the PGHD effects previously reported in the literature were reaffirmed by the patients. However, we discovered that, or I discovered that some effects could be dependent on the status of patient PGHD. I also removed, some of the really interesting findings was the need to remove or revise items that sounded negative. For example, I felt blue or sad. And this was because there was really a number of the stroke survivors who felt that reading these words in an outcome measure that they have to fill in or that they have to respond to when they are going through a lot of negative emotions can be really debilitating for them, because apparently reading these words, asking them to report these instances could be really detrimental. It could really bring up a lot of negative emotions. In fact, some of them said it could be very offensive, just reading these, just asking them these phrases or terms. Later on, I did respond to this feedback by removing negative items and revising them into sort of a good term like happy and a not happy scale. So instead of saying sad or happy and levels of them, I asked them to what extent they were happy about their health data or not happy. And stroke survivors also have varying levels of disability, and therefore competitiveness with themselves can help in terms of encouraging them to do better in their therapies, in their recovery, in trying to achieve certain goals and trying to be adherent to their stroke therapy. But when they are trying to compete with others, it doesn't help. And for many of the stroke survivors, in fact, for most of them, they do not appreciate level of competitiveness with others, especially with those who do not have any form of disability. And these came up because, again, the literature review gathered a lot of outcome measure items from both the health and technology space, and some of the technology-oriented outcome measures ask questions about sort of, ask competitiveness questions regarding their health data. So this is I think, a very interesting insight for stroke survivors, and I think it also has relevance really for designing technologies for people who have some form of chronic disease that they are managing, or some form of recovery on lifetime recovery that they have to go through. Because again, they are different levels, and therefore it might help if they sort of compete with themselves or try to improve their themselves and reach small goals, but not so much with others. Okay, so I also discovered that in 3 out of 6 teams discussed, stroke survivors' perspectives could vary with clinicians, and they varied in teams related to interest in care processes, personal care goals, and relationship with their care providers. But they had similar perspectives in teams related to health-related behaviors, feelings about their health status, and relationship with family or carers. And again, this highlights the need to consider the patient perspective, to consider the PGHD when either assessing, evaluating, or designing health information technologies. In step 5, the objective is to improve the PROM-PGHD item accuracy to represent perspectives and experiences of patients and their suitability and clarity. And the revisions were conducted as direct changes to the wording of the items, to remove or add response options or scales, and remove or add particular outcome items. Some items that were added were also an item, for example, to measure levels of frustration, levels of indifference in PGHD, and related to what I mentioned a while ago, some items that may make patients feel inadequate were also removed. For example, I felt that I had failed more than the average person. So, as has been implied by my talks so far, there's obviously an implication for design here. And essentially what I discovered from talking with stroke survivors, trying to ask them about the health effects or outcomes that can occur from using their health data. Essentially, we can identify certain technology usability features, which we can then use to evaluate how well a given health information technology incorporates those features. And so this year, we published a paper on developing a new set of design heuristics or guidelines to enable the better use of PGHD in stroke rehabilitation systems in the Journal of Medical Internet Research. And it was, I think the final copy has just been released yesterday, I think it was, so very new, out of the press. Now, a new set of heuristics can be used by technology producers during development of remote patient monitoring technologies. They can be used to improve the way health information technologies support patient use of PGHD in their design. And I followed a key methodology to develop a specialized usability heuristics. And there were 8 heuristics or guidelines in total. And I will be showing 2 here in this presentation. So here's an example. I know it's a bit small, but I will read it out. So the first is, the title is Encouraging Person-Generated Health Data. The definition is, the system should highlight PGHD indicating positive or improving therapy progress and provide them to patients with more frequency than negative or decreasing progress. And this really relates back to what I mentioned about sort of having negative terms or highlighting negative health data. This heuristic was formed from, and there's a bit of an explanation here, but essentially what it says is that if survivors see that their PGHD progress decline, they might lose faith in the system and not perform the exercises. In other words, it can be discouraging for certain stroke survivors. And related again to what I said a while ago, the second heuristic is evoking competitiveness with self. The system should present PGHD that indicates negative or decreasing therapy progress carefully and in a form that elicits a stroke survivor's competitiveness with the self. Now, as you see here, there's a tag here, there's a longer explanation here. There's also a few more bits of information for each heuristic or guideline, such as an example, for example, of how they can be applied and in what cases they may not be applied, or in what cases they can be confusing. And it really follows the template of what's considered the gold standard or the original set of heuristics in usability or user experience, which are 10 and by Nielsen and Mollick. And this is taken from their website. And for example, the first 2 is visibility of system status and match between system and the real world. And they have this short definition, and they ask the readers really to read up on more information on how to apply these heuristics in the real world. So that's really how it works, and that's how I tried to sort of pattern my own 8 heuristics that I developed. In the paper, we discussed how it was the first to develop a new set of specialized heuristics to evaluate how health information technologies incorporate features that enable effective patient use of PGHD, and that how was the first to describe how the identification of certain features from health information technology could lead to development of a specialized set of heuristics. And I implemented a systematic and detailed process in each step of heuristic development, and it really bridged certain gaps in previous development methods. Interestingly enough, there have been a number of specialized heuristics that have been developed over the decades since the first heuristics were released, but a lot of the processes they followed were a bit arbitrary in certain steps, and so I really improved that by applying a very rigorous step-by-step process. Okay, so summary. There are varying potential of PGHD effects, which necessitates a deeper understanding from systematic patient-reported measures, develop a framework for systematically measuring patient-reported effects. As a case study, the socio-technical context of simulated stroke rehabilitation systems was selected, and a PROM development process was augmented to create a new PROM-PGHD development method. The framework and PROM-PGHD development method can be applied for a variety of health information technologies for different health dimensions or conditions. And a set of heuristics were developed for PGHD outcomes in the context of stroke simulated rehabilitation systems from health outcomes identified. And again, this is the framework that I showed you all a while ago. And there are 4 components here. And as I mentioned, I'll be discussing the 3 outputs in more detail. And essentially, as you notice, obviously the key output here is really a type of patient-reported measure of utilizing PGHD. I have reported insights and learnings along the way as peer-reviewed publications. And the framework really encourages people or researchers who are developing their own types of patient-reported measure of utilizing PGHD to consider insights and learnings and report them in peer-reviewed publications to really gather feedback from colleagues, from experts, and to really sort of test their ideas and test their methods along the way, and of course to report the results, report key findings and insights. A third key output from the framework is a set of design or evaluation guidelines or similar for PGHD enabled. Because again, throughout my thesis, throughout my PhD, I realized that I learned a lot of insights related to design and of health information technologies and technologies that really develop PGHD or produce PGHD, and therefore we can really learn from that. And so the framework encourages future researchers to consider those insights and look at how they can be applied as a form of heuristics or guidelines for PGHD enabled. All right, so some of the skills that, some of the key skills, not all, that I feel I learned from the PGHD is on, first of all, generating evidence on health outcomes using structured research methods. A key skill is also producing high quality results, publications, and communication materials, including writing ethics applications, engaging with and managing stakeholders, and managing project timelines and sites. Some reflections from me in the past, but ethics and funding application and my studies that I've conducted in Melbourne has actually been Plan B study sites. Plan A sites were supposed to be in the Philippines, but there was a lot of, they really lacked resources to work on the study and the ethics applications with me. And I did get the approval from them, including about 600,000 pesos in funding, but they were approved only at the beginning of last year. So obviously I could not work on them. I might still work on them in the future as a form of future research, but they were no longer part of my PhD. I also had to shift my mindset from assessment to completion, coming from a master's degree where you finish a particular assessment, you submit it and you get feedback, and whether you're happy or not, that's it. You move on with the PhD. And I think, of course, in real life, most of you who are working at the moment probably know that, where you have to work on something and you have to work on it as best as you can, and it can always be improved. And it was the same thing really with my PhD. I sent countless copies to my supervisors. I'm really grateful for particularly Kathleen and Mark, and also Frances and Marie-Louise for really working on my drafts with me. And Kathleen and Mark have looked at my drafts so many times, and they always kept coming back. And I'm really grateful for them for working on those drafts with me. Key reflection is also honestly with my research team. I had the tendency, because again, coming from sort of an assessment-based degree, where I came with them and I felt like I was always being assessed for probably the first year. So I would always put my best foot forward. And I wasn't being honest with them about where I was struggling, what my pitfalls were, what my weaknesses were, what I was struggling with, what I didn't understand. Therefore, they couldn't really help me. But after about, I think it was a year or so, I realized that it was only derailing my PhD, and I needed to be more honest with them. And once I did that, it really helped me become a better researcher. It really helped me with my writing, and I really I think it was really the point where my PhD turned around, so to speak. Of course, the value of coordination and networking, that's very important in my PhD. Again, managing and engaging stakeholders. And then, of course, managing myself. I had to manage failures. I have a number of publications, as I've pointed out throughout my thesis, but it's always the case that, once you see the output, it seems amazing. It seems great, but there were a lot of failures in between. I have a try again folder that I developed that I made for my research activities folder, where I had failed conference presentations that didn't make it, but didn't make the cut. I have a number of failed submissions to certain publications, but I made the decision to make a try again folder about a year and a half ago, because I was really struggling with how to manage failures. I thought, you know what, they're not really failures. They're rooms for growth and improvement, and we can always try again. And managing work timelines and outputs as well. Myself, and sort of using the Pomodoro technique. I've been using it for more than 3 years now, since really the beginning of my PhD, and that really helped. Acknowledgements, I'd like to thank my supervisors, Kathleen, Mark, Frances, and Marie-Louise. The Strive project, which helped me implement my studies in Deakin University. Wei Peng Teo and Jessica Freeman. Research sites in Austin, Deakin, and Headway. I was able to obtain my Gentronics equipment from the University of Tasmania. And of course, University of Melbourne. I heard that there's a new name from CDTH for CDTH, but I won't say that now. I'll let the official announcement come through before I sort of say it here. And then of course, CIS, NARI, and of course, Newman College, and that's it. Thank you very much. If you have any questions, of course, please feel free to ask. Thank you.
Thanks very much, Ike, and congratulations to you as well as your supervisor, Kathleen.
Thank you so much. Thanks, Doc.
Does anyone have questions for Ike?
Yep, can I have one, please?
Yes, sure.
Yeah, sure.
So in your research, right, you had a good designed, well-designed methods, and you generalized your conclusion to that general IT design in health. But my curiosity perspective would be, why are you choosing stroke patients as your particular study objective? Is there any reason behind it? I want to know this.
Yeah, sorry, Sam. Why did I choose? Come again? I'm sorry.
Why did you particularly choose stroke patients or stroke survivors as your study objective? Is there any reasons or stories behind this?
Yeah. Thanks. Thank you. Thank you, Sam. That's actually a good question. And what I really focused, the reason why I really focused on stroke survivors and rehabilitation is because I wanted to I come from the Philippines, and when I began my PhD, when I was looking for a topic, I was really interested in stroke rehabilitation for a variety of reasons. And one of those reasons was because the instance and burden of stroke in the Philippines is really high, and the access to stroke survivors in the Philippines is really low. For example, I come from a city in a region of about 3 million people, and we only have one child neurologist in a city of 3 million. And she's, that's her specialization, child neurologist. And in that region of 3 million people, you have several islands as well. I'm from the main island, but there are many islands as well. And she has had to travel every now and then. And you put into context as well that there are some terrorist groups in those islands. It's very difficult for stroke survivors to leave those islands. They have to take a ferry or a pump boat just to go to the main city where some of the stroke units are, to go to their therapy or to be treated for stroke if they have it. And it's not uncommon for patients to unfortunately die or have their disability really worsen in the trip from those islands to the Philippines. Prior to doing PhD, I was talking with the neurologist who I worked with in the past, and that's why we thought that maybe this is a good idea. And that's also the reason why my studies in the Philippines did push through. As I mentioned, she's the sole child neurologist in that region, and it was difficult for her to spend more time in my ethics and really to work on our study, which we were supposed to be doing together in the Philippines. And so, yeah, that's the reason why I chose stroke rehabilitation as a case study.
Okay, very good story, Ike. So I can see the rationale and the true values behind it. Thanks.
Thank you, Sam.
Ike, this is Brian.
Hi, Brian.
Chapman. Congratulations. I'm sorry to see you graduate just when I get here, but I had just kind of a basic question about data. And early on in your presentation, and you're talking about the person-generated data or whatever, and the kind of data quality issues. Do we hold patient-generated data to too high of a standard relative to clinically generated data? I've had so many blood pressures measured over my lifetime that I would never trust because they're dropping the mercury so fast. It's got to be plus or minus 30 millimeters of mercury. But it doesn't seem to ever be questioned there. And so that's kind of the first question. And then what would be kind of the correct kind of metadata scheme to address just kind of broadly kind of where the data is generated and how do you kind of address it to make it trustable in general?
Yeah. Thanks, Brian. Good questions. On the first question, in terms of the quality and I guess accuracy and safety of those data, I would actually lead you to Bob. Her PhD is really working on quality and safety of using PGHD, but I know her focus was really on clinical wearables. But in my study, what I really focused on was sort of how I really focused on the question of, regardless of the accuracy of health data, when people or stroke survivors or patients use a particular health information technology, how are they affected by the process? And how can we measure that in a systematic way? So we know that there are questions with quality and accuracy and sometimes the timeliness of health data. But given all of those variables that you just described, how then can we, given all of those variables that you described, it only adds to the fact that, how people can be affected by their health data, really needs to be measured. And so, yes, health data can lack in accuracy at sometimes, but how people are affected by them is what we try to focus on. So if, for example, sometimes I use a blood pressure app as well, or sometimes I use a fitness, sort of a fitness app as well. And sometimes I'm encouraged by it. Sometimes I feel that it's not working for me. Sometimes I stop using them, and it's very variable. And the idea really is to sort of standardize how we can document and record those variability, the variable nature of the effects that these health data can have on stroke survivors and on patients. And I'm sorry for sort of, I guess, a very, I think it was a bit disjointed, my response there. But the point really is that while there are some inaccuracies in some of the data, I didn't really focus on that. Instead, I focused on the effects that it can have, the health outcomes it can have on people who use those health data. And yeah, thanks, Brian. If it wasn't clear, let me know.
Sorry. Hi.
Hi, Peter.
Yeah. Okay. Congrats. Sorry, my basic question is, in terms of progressing in the use of technology for health monitoring. So, do you think that what a clinician might take as success in the use of health data would be what a patient will take as success in terms of the outcome? Or is there a kind of a point where there will be a need to resolve the perceptions in terms of what a successful technological use of data in monitoring health would be? Yeah.
Thanks, Peter. And I kind of wish that you asked the question for Brian, because I realized that you put it in a better way than I did a while ago. And that's exactly the point, that yes, what clinicians may see as success is indeed in many ways and in many instances different from what patients see as success. And in my conversations, for example, with some stroke survivors, especially when I spoke with clinicians and stroke survivors, clinicians often really focused on functional outcomes. Can they raise their arms a certain degree for example, can they raise their arms from, let's say, 45 degrees to full 180 degrees? How many seconds or minutes can they do a particular exercise? But for stroke survivors, some of them really focus on, can I reach that shelf? To what extent can I comb my hair? To what extent can I put on a shirt by myself? And when you look at health data, what matters to certain clinicians could be different to what kind of health data matters to certain patients. Clinicians may focus on, again, those more granular data, whereas patients focus more on how it makes them feel. Does it make them feel better about themselves and interact with their family or their carers better? Or will it discourage them and make them give up on their recovery? And they mentioned some, I talked to some carers where they talked about undergoing, because one of them had a comorbidity, and I think it was diabetes, and they attended a particular study that helped them monitor their diabetes. And they mentioned that, seeing how their data would tend to go towards a negative at some point, and not capturing their emotions and their feelings and how it affected them was really detrimental, because they were going through some negative emotions, for example, that discouraged them from pursuing their tasks or goals. But these clinical data, were not capturing that. In other words, it was showing that they were failing, but for them, they weren't failing. They were just in a phase where they were trying to improve, and they were going through a certain phase in their lives. And they were going to improve for them, but it may not be now. But having this data blare at them that, you're not yet improving, you have to improve now, was only making them more discouraged than it was giving them a more positive effect. So yes, there's definitely a difference, and that's why we need to allow patients to self-report their outcomes in a more systematic manner. Thanks, Peter. Thank you.
Thanks, Aiki. Does anyone have any questions for Aiki?
Well, I'd just like to make a congratulatory comment and say that reflecting on it, it has been a long and winding road, Ike, but we're very proud of you. You've been one of our own in terms of coming to us to start your master's degree in IT with a health specialization, and you know, showing your talent then and staying with us right through to the fellowship by training program. So it's been very exciting, and you've been a bit of a guinea pig at some stages along the way, but it's been delightful to work with you, and it's just a joy to see you at this point. Thank you.
Thank you so much, Kathleen. And I've mentioned this before, but again, I'm very lucky to have you and Mark as my sort of primary supervisors, and also really lucky to have Francis and Elise as my supervisors. I've really learned a lot from you, and I'm also very lucky to be a part of two really great organizations or institutes in the University, School of Computing Information Systems, and of course, HABIT now, Center for Digital Transformation of Health. I'm really grateful. I've learned a lot from all of my interactions with many of you. I'm so happy to have all of you here. Many of you I've met along the way, my PhD, in many different forms, as a PhD candidate, as a colleague, as a friend, organizing doctoral academies, and Peter was with me working on that. So thank you all. There's just so much to say, but I just wanted to say thank you Kathleen again, and everyone who attended this presentation and who worked with me in helping me get here. Thank you.
And in other times, we would all go out and have a drink together at University House. Hold that thought.
I think you deserve a big clap, Ike, for making it this far and for doing your computer seminar. So
thank you so much. Thank you. And again, thanks everyone for joining me. And Kathleen, looking forward to catching up in person, if not at least at some point when things start.
Indeed. Yeah. Good. Okay.
All right.
Thanks.
So thanks everyone for attending today's lunchtime seminar. Just to let you guys know that our next seminar will be on next Thursday, the 6th of August, and we have Professor Renato Belemo from the Austin, who will be presenting on the Data Analytics Research and Evaluation Center. So look forward to seeing all of you there next week.
Thank you, Noah.